All right, I have two more cases for you guys. The first one is a 55-year-old female with chest pain, and this comes from one of our NPs, Tyler. He's a good dude. He works up mostly at Monroe. I like him, but he's dead to me because he shaved his beard. I mean, he's pretty bearded out in this photo. It was much sicker than that, but he shaved it, and now he's dead to me. I mean, he's missing out on the powers of the beard. Look at some of these famous people from history with beards. Abraham Lincoln, Gandalf, Leonardo da Vinci, the man Jesus, Chuck Norris, the Prophet Muhammad. What's that guy? The guy who did the theory of evolution, Darwin. And my boy Socrates. So Tyler, you're missing out. I hope you die a young, smooth-faced death. All right, so here's the patient that he had. Chest pain started 4 days ago, pressure in the middle of the chest. 55-year-old female that arrives in the ER with chest pain. Began 5 days ago with no aggravating or relieving factors. Previous history of DVTs, which she's supposed to be on Xarelto for, but she stopped taking it due to financial concerns. She's also describing jaw pain, mid-thoracic back pain, and numbness and tingling to bilateral upper extremities. Denies any recent travel, denies any recent URI symptoms, denies any abdominal pain, nausea, or vomiting. Again, this history gives us our pretest probability for which we will interpret the EKG. Okay, overall, the main concerning thing here is, well, it sounds like this might be a PE, right? History of DVTs, not taking her Xarelto. The main thing on here that concerning to me is the jaw pain as well as bilateral radiation. Okay, I have no data to confirm this, but whenever someone tells me they have radiation to bilateral arms, more often than not, they have pathology that needs to be fixed. All right, so here's our previous EKG. And again, this is just to establish the baseline. I recommend you pause, go through it, write down your findings, and think about what your interpretation is. All right, so here's what I see. First off, I see normal sinus rhythm. Okay, the rhythm strip, which is lead 2, there is 1 P for every QRS, so we're sinus. Okay, the rate is not fast. When you're looking at the rhythm strip and evaluating for sinus, you can also get a little peek at the P waves, right? Like for this person, we definitely have abnormal P wave appearance. Like it's notched here in this lead 2, and it's biphasic up here in lead 1 and lead 2, which is very suggestive of left atrial enlargement. For the access, it's up in 1 and up in AVF, so normal. Okay, for the intervals, again, I don't see any prolongation of the QTC or QRS. For the ST segments, what I see is, number 1, we have inversion AVL. Again, this is just a screening EKG. Whether or not that's relevant depends on what's going on with the patient. I don't see any significant J-point deviation. When we look at all these leads, like the J-point's lining up with the PR segment pretty much. I don't see any hyperacute T waves, like the amplitude of the T wave is not high relative to the QRS, and it's not very wide. So overall, like non-specific EKG, I see no acute signs of pathology. And again, this is just to establish a baseline. All right. Now, here's the first EKG at 16:56. Same thing, pause and do your thing. All right, now here's what I see. Number 1, once again, normal sinus rhythm, 1 P for every QRS. We have this same P wave abnormal appearance with the notch 1 in lead 2 and the biphasic 1 in V1, okay? The access, it's up in AVF and up in 1, okay, so a normal access. For the intervals, once again, I see no prolongation of the QTC or the QRS interval. Okay, for ST segments, let's go through here and look. And what we're looking for is J-point deviation and or hyperacute T waves. Number 1, it looks like AVL is flat and not necessarily inverted. Okay. Number 2, when we look through here, I don't see significant J-point deviation. Like maybe like a 0.5 millimeter in 2-3 AVF, but nothing crazy. Also, note the linearity of these ST segments here. Again, that's always concerning for coronary artery disease. But overall, like non-specific, and I don't see anything acute. Like there's no acute signs of infarction, ischemia, or arrhythmia. So, you know, the workup for this patient, number 1, was geared towards ACS as well as PE stuff. So while they're working her up, it doesn't have a PE, but her troponin does come back elevated, like around 200 to 300. Okay, here's a repeat EKG at 18:56. after the troponin came back and after she was complaining of a little bit worsening pain. Now, what I see, okay, number one, like we said, normal sinus rhythm, normal rate, normal axis, normal intervals. The main thing here is the ST segments. Number one, which I hope you all picked up on, is the ST depression, inversion, and linearity in AVL, okay? Remember, every time you see that, especially if it's new, a huge red flag should go up, okay? Looking at the other ST segments, we have repolarization abnormalities, again, which are new from the previous one. Up here in lead 1, we do have J-point depression, as well as linearity and straightening of this ST segment. No real J-point deviation here in this lead. We do have maybe 0.5 millimeter here in lead 3, which is new compared to before. Same thing over here in AVF, maybe 0.5 millimeter, but nothing crazy. Up here in V2, we do have changes, specifically slight J-point depression, and again, inversion and linearity of this ST segment. And look at that, the linearity of this ST segment is greater than the amplitude of the QRS. Same thing over here in AVL. No real J-point deviation or straightening in V3. Over here in V4, 5, and 6, again, I'm not seeing much. I don't see much J-point deviation or straightening over here. So again, overall, this EKG, again, is non-specific and non-diagnostic. The development of these repolarization abnormalities is highly concerning for ischemia or impending infarction. So this was 1856. Here it is at 1911, okay? And again, it's obvious here. Like, look at this. This is clearly an infarct, okay? Over here in 2-3 and AVF, we have about 2 millimeters of ST elevation compared to the isoelectric point, okay? Look at this concavity of this ST segment. This depression in AVL has got significantly worse. Now it's maybe 2 millimeters. Same issue over in here in AVL. Not only is there depression, but look at the morphology of this ST segment, how straight it is and how downsloping it is. Now we have significant ST depression here in this lead, okay? It's not two contiguous leads. If we had it in V3 or V2, that'd be concerning for a posterior infarct. And we have developed some J-point deviation over here in the lateral leads. Like in the lateral leads, when we compare the J-point to the PR segment, there is maybe 1 millimeter of elevation. Okay, so clearly this is a STEMI. Like, it meets all the criteria. ST elevation, myocardial infarction needs to go to the cath lab. The other issue here is, which is interesting, which I've mentioned before in previous videos. I mean, if you look, again, it's a diffuse repolarization abnormality. Like, look, like we have repolarization abnormalities literally like in every lead. Like, there's repolarization problems in pretty much every lead, with the exception of like AVR. And remember, when you see those diffuse repolarization abnormalities, think those 4 things: coronary artery disease, toxic problems, metabolic problems, or brain problems. For coronary artery disease, you need to distinguish between a type 1 and type 2 infarct. This was a type 1 infarct where there's occlusion. A type 2 infarct, which we saw in previous videos, is because there's a mismatch. She goes to cath, and look at this. Look at this. Look at all this jazz and this junk in here. Like, no blood is getting through. She got a stent, and she did well. Okay. Also, interestingly enough, this patient had a normal stress test 8 months ago. Okay, like, I know stress testing is the standard of care, and we say they're good for anywhere between 1 to 3 years. If I'm not going to go into it now, but if you do an extensive literature search, the negative pretest probability for certain stress tests are not so good. But again, I mean, we still do it, but I mean, I'm not saying every patient you shouldn't trust the stress test. It's just something to think about. All right. I got another case that happened just yesterday. It's a 40-something-year-old male with chest pain. This one comes in from Dr. McTagg. He's one of our third years. There's his picture. I looked up the meaning of his name, and it's derived from Gaelic, Machtig, which means poet, philosopher, or bard. I mean, that's pretty cool. McTagg's a good dude. I got no beef with him. So here's the case. This patient with no significant past medical history presents for evaluation of chest pain that onset after he was playing basketball. Good grammar, McTagg. States it came on about 1 hour prior to arrival, and then he stopped exerting himself and came in. McTagg, read a book, bro. Does report that he has a history of early cardiac disease, including a heart attack in his father, age 55. The patient denies any smoking and denies any shortness of breath, cough, abdominal pain, or vomiting. Does report he had some slight nausea as well and some slight numbness of his left arm when the symptoms came on. States his chest pain persists but does not go into his back. Says he has not had symptoms like this before. States it does feel like indigestion. All right, so overall, I would say our pretest probability for coronary disease based just on this history, I'd say is moderate, okay? He's young. The only risk factor he has is family history. The things I don't like is the onset was when he was exerting himself and he had to stop, and also that he has radiation to his arm, okay? So here is the first EKG at 2116, and we have nothing old to compare to. Now, here's what I see, okay? Number one, again, normal sinus rhythm. Okay, we have 1P for every QRS. The rate is normal. We're all good. I mean, there might be different P wave morphologies, maybe a wandering atrial pacemaker, a topic atrial pacemaker, but I mean, who cares? That's not really pathologic, right? For the interval, or for the access, up in 1, up in AVL, so normal access. Intervals, I don't see any prolongation of the QRS. For the QTC, just visually. The halfway point, I mean, maybe we're approaching there. I would defer to the machine for what the QTC is, okay? The main thing here is the ST wave segment. So let's go and look through here. Number one, there is no inversion in AVL, but if you note, there is this linear, this ST segment here, okay? Up in lead 1, same issues. I see no J-point deviation. I don't really see any linear of the ST segments. Up here in lead 2, maybe, I mean, there might be maybe half a millimeter J-point deviation. That might just be artifact. It's not present on this one. Maybe a little bit on that one. In lead 3, we do have what looks like some J-point deviation, okay? Again, is that real or artifact? Hard to tell. And again, we have this linearity of the ST segment, okay? No real J-point deviation here, but again, linearity. Up here, maybe some deviation in linearity, okay? AVF, I don't really see, I mean, maybe half a millimeter of J-point deviation, but nothing crazy. But again, note the linearity of these segments, okay? Like, look at this, like, look how straight this line is, especially compared to the amplitude of the QRS, okay? Up here in AVR, maybe slight J-point deviation, nothing crazy, but again, note the linearity. V1, I don't see much J-point deviation. Same thing here in V2, I don't see much J-point deviation. But again, note the linearity of this ST segment, okay? Same thing here in V3, maybe half a millimeter J-point deviation, but look how linear the ST segment is. Over here in the lateral leads, I'm not seeing much. Not really much J-point deviation, maybe a little bit of straightening, okay? So, my overall interpretation, is this an infarct? No, there are non-specific repolarization ST wave abnormalities, which are non-diagnostic. So 2116 with nothing old to compare to. Here we have an EKG at 2324. All right, so let's go through it. Number one, normal sinus rhythm. Rate is normal. We're all done. Access is normal up in AVF and up in 1. Intervals again look normal. I see no prolongation of the QTC or QRS. Now let's look at the ST waves, okay? I hope you all picked up on this as number one thing, okay? Number one, we have J-point depression in AVL, and look at this inversion in linearity, okay? Bad, right? Like we see this again and again. Number two, up in lead 1, same issues. We do have slight J-point depression, and again, look at the linear of this segment, especially compared to the amplitude of the QRS. It's definitely over half the size. Here, no real J-point deviation, but we have developed this Q wave, okay? Remember, the definition of a Q wave is the first downward deflection after the P, and the definition of a pathologic Q wave is a Q wave that's greater than 1/4 of the amplitude of the QRS, and this definitely is. Like, that's definitely greater than 1/4 of the amplitude of the QRS. Down here in lead 3, we do see J-point deviation, okay? We also have this, huge Q wave that's almost as big as the R wave. Same issues over here in AVF. We have J-point deviation, specifically J-point elevation, and a Q wave that is developed. AVR, I'm not seeing much J-point deviation. Same thing in V1, not much J-point deviation. In V2, now we've developed J-point depression of approximately 1 millimeter. Not much here in V3. Same thing, V4, 5, and 6. Well, maybe there's a little bit of J-point depression right here, nothing too crazy. And McTagg says to me, so he gives me the EKG. He's like, what do you think? I'm like, well, would you send him to the cath lab? He says, well, it doesn't meet criteria. And I said, screw you. That's the whole thing. Like I've said before in my previous videos, and when I want to get across to you guys to take for your career, is that STEMI is an irrelevant term and an irrelevant concept. What we need to think about is there symptoms, risk factors, and focal repolarization abnormalities, and does my patient have an occlusion that needs emergent intervention? Ooh, one more thing I forgot to mention. It's pretty close, but we got T-wave in V1 that might be bigger than the T-wave in V6. Again, non-specific, but one of the repolarization abnormalities that are concerning. Okay? So what happens to this patient? Okay? First troponin 13, second troponin 49, third troponin 20,000. They did call him a STEMI. They call him a STEMI before the 20,000 troponin, by the way. And here's what he had in RCA occlusion. Like, look at that. Like, no flow is getting through here. And here it is afterwards. Look at that. It's pretty. Inferior ST elevation, myocardial infarction, occluded large vessel proximal RCA, severe disease, circumflex, successful. All right. Well done. All right. So that's all I have for these cases. Okay. Hope you enjoyed them. The teaching points, once again, things that I've said before, which I hope is getting across to you. Number one, STEMI is irrelevant. Its symptoms, risk factors, and focal repolarization abnormalities. Number two, inversion and or depression in AVL, especially new in the proper clinical setting, should raise a huge red flag. You should be aggressive with that patient, stay on top of their pain, and think about serial EKGs every 15 to 20 minutes. Number three, diffuse repolarization abnormality. Think about, those things, coronary disease, toxic metabolic, or brain problems, and that's all I got. Oh yeah, also grow a beard. I hope you enjoyed it. Any questions, ask me in person. Peace. Patrick is out. Stop.